And I do want to echo actually Stephen's comments around there is a lot more work to do around consumer engagement and education and empowerment and culture. However, that's not necessarily what I'm going to be talking to you about today. I thought it'd be a good opportunity to share with you where things are at Safer Care Victoria and touch on some imminent legislation change in relation to information sharing, which you may be of interest, and also have a bit of a dialogue around culture. But I do want to share with you some insights around the Central Event Programme, which I've been overseeing now for 3 years. And we released our 4th report about 2 weeks ago. And for the first time in 3 years, there was zero media attention. So I think that says something about what's changing in the system. So I take that as a positive. So we've obviously reached our 3-year milestone. We're entering into our 4th year, and obviously it's these sort of times where you revisit your strategy and think about why are we here, what are we doing, and that's the process that we're actually undertaking as we speak. And whilst our vision, our purpose and our values haven't changed, what we have decided that we needed to be much more clear about is why we're here. And so hence our aim now for the next 3 years is to really focus on how we start to shift the dial and I guess consolidate the work that we've done, but really focus in on some key areas of improvement so that we can make healthcare in Victoria more effective and person-centred and safer. So how will we do this? So what our sort of 4 strategic priorities are looking like at the moment. We know we can't do this on our own. We need to do it with you. So partnership and planning is going to be obviously a key part of how we go about this. We know we need to invest in leadership. Stephen referenced before the importance of culture. Well, leaders set the culture of the organisation, and we need to continue to support our existing and emerging leaders in the system, and we will continue to do that. Monitoring and assurance, so in partnership with our colleagues in VAHI, we need to get better. Are we measuring the right things? Are we getting the data to the right people at the right time? Are we empowering you as clinicians to be able to continuously improve the work that you do? And to that end, how do we support you in that improvement space? So how do we equip you with the skills and the know-how and the resources to drive improvement, but also at a system level, what is it that we should be leading and driving and focusing on? And ultimately, it's really taking that strategic approach. And in this context, how do we drive better and safer surgical care? And I will call out, we probably haven't done a lot in the surgical space to date. If we look at the clinical networks, they are largely, traditionally have been focused around specific groups or specialties. There hasn't been an awful lot in the surgical space outside of cardiac. There has been some. So we want to obviously change that. We've obviously now established the Victorian Perioperative Consultative Council with David leading that. And we will be obviously supporting that council and working with yourselves and VASM into the future. And you may know that we undertook a partnership last year with the Institute for Healthcare Improvement, IHI, and we are now using their model for improvement as a way forward and to drive the improvements that we do, but also to support people in learning their techniques, their evidenced strategies that they've been using for probably 3 decades now, and really using that in much more of a defined way and in a systemic way. And so essentially what we've tried to depict there is how our sort of strategic priorities line up in that quality system model, and then obviously then using the model for improvement to drive change. So we are in the midst of a restructure as well. So things are changing and not unusual in government, I'm learning. So whilst in essence our core reason for being hasn't changed, there will be some slight changes in what we look like. And as of Monday next week, this is the sort of high level structure. So I will no longer be the Director of Consumer Partners Branch. I'll actually be the Director of the Centre for Patient Safety and Experience, and I'll tell you a little bit more about that. And essentially we've tried to design more of a matrix model where we have some very focused externally facing centres. So that's what the centres represent. So the Centres of Clinical Excellence are what you would know now as the Clinicians as Partners branch, where the clinical networks sit, and they will continue to be represented in that branch, but we're trying to take a bit more of a population focus as opposed to the discrete subspecialties. That will be a transition. It's not going to be a switch and networks disappear. That's not our intent, but we want to get a bit more focus in terms of population groups. So there will be 4 centres of excellence in that group. So women's and children's acute care, which is where we want to do more in the surgical space, and we'll have one around aged care, so older people, and then there'll be one around chronic diseases, prevention and mental health, which might sound like a bit of a weird hodgepodge, but essentially I guess it would taking a broader focus on some of those broader issues that not only touch acute care but also primary health care and community. So it's taking a different approach in our thinking there, and that will evolve over time. And I won't sort of read out all of those because you'll get these slides, but I just wanted to signal to you the changes that are coming. So the Centre for Patient Safety and Experience, which will be the branch that I'm leading, I will be taking on the Secretariat support for the Consultative Council, so I'll be working much closely with David Waters and obviously Philip and the VASM crew here, and also the COPM, so the Obstetric and Paediatric Council. I'll also be taking on the Voluntary Assisted Dying Board and the work around the portal and the support we provide there. I'll continue to focus on patient experience and how we respond to patient feedback, but also responding to critical adverse events in the system. And then the Central Event Programme currently sits with me in my current branch, and that will continue to be so. And then we want to really try and focus the review work that we do. So at the moment, the team that coordinates central events also does our review work, and you can imagine sometimes those worlds collide in terms of the speed the cogs turn. So we want to sort of liberate those resources so that they can really do some real deep dives when we want to do a safety system review, but also support the sector in capability. So looking at other methodologies outside of root cause analysis, which I know many of you probably groan when you have to do one. And I saw Stephen had a slide on RCAs that he chose not to talk about, but I can imagine what he was going to say. So we want to broaden the skill set there and deepen people's knowledge about contemporary safety science, essentially. The system safety partner is a team who will have an internal facing role, but also will be working externally. And they will really be driving that system level performance monitoring, working with VAHI around the measures that we look at and report to you on, and also looking at some deeper dive analytics, so volume-based outcome work. We've done some work recently on tonsillectomy and adenoidectomies in paediatrics, because we saw in the Atlas of Variation there was a 9-fold variation across Victoria in terms of whether you get your tonsils out or not and the outcomes you may experience. So we've done a specific piece of work on that. We're doing some work on Whipples as we speak, and so we're really keen to share that with you and work with you. And so Helen Rizzoli, who's heading up that team, will be supporting that, and also focusing on the leadership development and translating those lessons into the health system and working with health services in development of their capability. So let me touch a bit on the 2018-19 report. So as I said, this is our 4th report now, and whilst what I would say is we've probably plateaued a bit in the last 2 years, what is encouraging to see is since our inception, we have seen a rise in notifications, and that's been a very deliberate move on our part because we knew we had a lower than expected reporting culture in Victoria. When we looked at our other partners in other jurisdictions, the numbers that we were seeing in the Central Event Programme didn't quite add up if you think of the size of our health services and the complexity of care that we deliver. So there's just some highlights there in terms of the year that's been. And I think what is interesting is we haven't really seen much of a shift in the sort of national defined categories of central events. And we continue to see a significant volume in what's the Victorian only other category, and I'm going to take you through some of the details behind that. What is reassuring though is some of the improvements, and whilst they're process improvements, I think they're good signals in terms of how health services and clinicians are engaging with us, and we're seeing much more presence of consumers involved in RCAs, much more external experts coming into RCAs, and really seeing some improvements in recommendations that are being made. So we're seeing a maturity, I guess, in terms of what we're seeing in the reports. What we're yet to see, though, is the so what. So, are those recommendations being implemented, and are they sticking? So that's our next focus, is actually following through on that and seeing the so what. I think if we look back to the last few years, what is interesting though is, particularly in the surgical space, one would hope that we would not be operating on the wrong patient or body part, given it's 2019 and we've had surgical checklists in for a while and time out. Yet whilst the numbers are very small, we're still seeing cases of that in the system. So, I guess, I start to ask the question of, well, is there something we're missing here? And if we think of the Australian Commission on Safety and Quality's position now with the wholly avoidable events that they've released July last year, they would argue that these events are essentially what's known in the NHS as never events. It's not something that necessarily sits well with us at Safer Care. I think if something was wholly avoidable, it wouldn't happen. So, there must be some systemic reasons that we're perhaps not focusing on. And so I guess I'd throw open the challenge to you as clinical leaders in the system. And also retained instruments or other material, and we've put in brackets there unretrieved, because that's actually how a consumer sees this. It's not that they've kept it in, it's just we've not took it out. And we have, we're continuing to see, in the scheme of things, actually reasonably higher than expected numbers there. Whilst we've had only 10 last year compared to 12 the year before, that still seems in proportionality a large number of events where we've harmed people because we've left stuff in them. And this is often the category that we have the most arguments about with health services, I have to say, in terms of is it harm or isn't it? And we found it and we took it out, so no harm was done. Well, according to who? So that is an interesting debate that we continue to have. And in the report, we break that down in terms of what they are. And what's interesting is actually when we do get notified of these, we actually start to pick up patterns. And in the last 2 years, we've picked up patterns around certain bits of equipment, which we've then been able to escalate to the likes of the TGA to say, hey, this bit of kit seems to keep breaking and snapping off and being left in people. Is it happening anywhere else? So it's actually really important that we know about this stuff. So I'll just move on from that. In terms of the Victorian only category, and the reason that we have kept this category, even with the new definitions, is this is really our safety net, because we don't see your incident management entries. That's obviously written, that's your data. It does get transmitted to VAHI now in a minimum data set. However, it's not a live sort of stream. So we are reliant on you telling us of these sort of other adverse events that have caused serious harm. And you can see the breakdown there. And I think what's also interesting is the majority sit in the clinical process and procedural space. So, 38 patients were harmed or died as a result of failures in clinical processes last year. And that's more than the year before, so 13 more than the year before. And some of that has been down to delayed assessments, which have led to misdiagnosis. But in particular, it's more around the procedures that have not been completed fully or inadequately performed. So again, I think there's a role here for us as a system to going back to what was being said before around standardisation, pathways, clinical quality registries. How do we actually learn from these events and actually, make it the system better and safer? So in terms of some of the work that we've been doing in the last year and the year ahead, so we released the revised criteria from the Commission last year, and we've also released a guidance document for the Victorian other category. And if you haven't seen that, I would encourage you to go on our website to have a look at it. And what we've tried to do is distill down the patterns that we've seen over the last 3 to 4 years of those common adverse events, and try to share with health services some clarity on what you should be reporting, because again there seems to be a lot of confusion around what should we be notifying you of. So we've tried to be a bit more precise about that. This year our focus is very much, as I said before, on training people in different methods, so London Protocol, AXIMAP, really focusing on human factors and equipping you with deeper knowledge in that space. Just culture, which I'm going to talk about in a second, and we'll then accompany that with tools and fact sheets that you can then use. If you're not familiar with the new central event categories, I have got them up there on the slide. This will be circulated, I'm sure, afterwards. But just to remind you that they have changed, and they've actually broken down what was category 1 into 3 categories, and they all relate to surgery. So if you don't know what they are, I would suggest you go and look it up. So some of the other work that we're doing looking forward, and again, this is a big debate that I tend to have with colleagues, is what's an acceptable complication and what is harm, what's an adverse event? And that still seems to be something that we tussle with. What we have seen in the last few years of data is a pattern in terms of adverse events relating to anticoagulation. And we've also picked up a pattern in relation to bowel perforations and colonoscopies. So Andrew Wilson, who many of you will know, our Chief Medical Officer, is actually leading a piece of work there to actually unpack that a bit more and actually start to try and understand what's going on there and what do we need to do to improve that. So that's just in its early stages at the moment in terms of data collection, and then we'll be coming out and talking to yourselves. I do want to just spend a moment on this because it is quite complicated, and don't worry about the numbers on the diagram, but as of July this year, we will be releasing and activating amendments to the Health Service Act around information sharing. And essentially what this enables us to do is to more easily transmit information that would have normally not been transmitted, and in the purpose of quality and safety. So essentially it means that the Secretary, with the likes of Safer Care and the Victorian Agency of Health Information, can transmit confidential information. Health services can tell us confidential information, whereas before there were limitations to what you could share with us. And you can actually start to share information with each other under certain conditions. Or you can appoint a specialist advisor to do that and act on your behalf and sort of liaise with the government. So as of I think it's 1st of August actually, these amendments take effect. It's called the Omnibus Bill, if you're not familiar with this at this stage. And there will be more information coming out to you, but I just wanted to signal to you that there's going to be some changes, and hopefully it'll make our lives a bit easier in terms of trying to improve the system. I know I've got to wrap up, so I just want to touch on just learning and culture. I'm not going to go through all my slides, but this is something that we've really been trying to emphasise. I still hear stories of adverse events that have the immediate response is stand the clinician down, or sack so-and-so. And we still haven't quite got to the space where we're actually taking a step back and actually trying to understand, well, what was going on for that individual at the time? Were they set up for success? What led them to make the decisions that they made? And, I think we all know the phrase, the system is designed to deliver the results it gets. And so I think, we really need to start thinking about, when we are reviewing adverse events, to really apply this just culture lens and human factors thinking if we're going to start seeing improvement. Because I think if we keep going in the same direction and keep doing the same reviews in the same way, sadly, we're not going to achieve the change that we all want to achieve. So we will be doing a lot more work in this space with you and ourselves, and we look forward to having that conversation with you into the future.